Last year, we were honored to share our efforts with Surgeon General Jerome Adams, and today we're honored to welcome the Assistant Secretary of Health, Admiral Brett Giroir. Admiral Giroir is the 16th Assistant Secretary for Health at the U.S. Department of Health and Human Services. As the Secretary's principal public health and science advisor, the ASH is leading America to healthier lives through promoting vaccination across the lifespan, developing the nation's report card for health, also called Healthy People 2030, ending the HIV epidemic in America, and improving the lives of all suffering health disparities, with a special emphasis on all living with sickle cell disease. Admiral Giroir is also the head of the U.S. Public Health Service Commission Corps and oversees the Office of the Surgeon General. In addition to his role as the Assistant Secretary for Health, Admiral Giroir is responsible for coordinating HHS's efforts across the administration to fight America's substance use crisis, as well as overseeing the nation's COVID-19 testing efforts. He also represents the United States on the World Health Organization Executive Board. Previously, Admiral Giroir served in numerous leadership positions in the federal government and in academic institutions. Most notably, he was the first physician to serve as an office director at the Defense Advanced Research Projects Agency, or DARPA. As a pediatric critical care physician, Admiral Giroir brings that hands-on, patient-centered perspective to his work as the Assistant Secretary for Health. Please welcome Admiral Giroir.
First of all, really, I appreciate the opportunity to be with you today. I am with you today because this is such an important, critically important topic that has sort of taken a second level priority because of COVID in much of the country. But we're all trying to raise its priority again because of the importance of it. COVID will go away with a vaccination. Substance use disorders won't. We're still going to be facing this far after COVID is gone, and we're going to have to deal with the reality of really the intersection of two pandemics, both COVID and our substance use crisis in the country. So I'm just going to make a few remarks sort of at the national level, a few things about Ohio and specifically that you already know. Some of the ways we're adapting a little bit at HHS, and then I know you have some questions, and I'm very interested in learning from you on the front line. So I think most of you know these data, but we're all busy in our own areas. These are the latest national data published by the CDC on mortality. Of course, they're about 6 months behind because of the slowness in mortality, but this does represent the 2019 end of year compared with 2018 end of year. Yes, it's provisional. Yes, it's predicted, but 98.7% of all autopsies are all classifications. So this is pretty good data. And I think, as all of us know, quite disturbingly, is that the gains we saw throughout 2018 and early 2019 have really all been wiped out, and that over 2019, we've seen a 4.8 increase in mortality from the previous 12-month period. So our official numbers, still be a few months before the official numbers, we will have tragically lost over 71,000 individuals to substance use disorders. And of course, this does not count alcohol. This is really the opioids, the methamphetamines, cocaine, other similar drugs. Next slide. This is just a snapshot from that data piece, where if you are a deep orange state, your percentage has gotten much worse of mortality. If you're in blue, it's gotten better. And after a lot of improvement over a period of time, Ohio's mortality was up almost 7%, as many states were. We had seen, Ohio is very different in a number of ways. We'll get to it just in terms of the pattern. But you see that many states that had been very high and sort of characteristic of the outbreak, like the New Hampshires, are doing better, but much of the country has seen a reversal of many of the gains that were made throughout 2018 and, in fact, early 2019. Next slide. On the next slide, please. This looks at the overdose deaths by drug, again, looking at the year-end totals that are provisional. I think all of us realize that synthetic opioids are still the #1 offender, and it's mostly fentanyl and fentanyl analogs. We do get urine toxicology reports, anonymized, of course, and in Ohio, it is the place that carfentanil is always showing up. It rarely shows up in other states, but clearly in Ohio, that's always something that we do detect. So synthetic opioids, mostly fentanyl. As we've seen a pattern of psychostimulants with abuse potential, mainly methamphetamine, really, which is the orange line, which has really increased really dramatically. And it's the fastest increasing drug. And I think, as you have said earlier, we're seeing across the country methamphetamine being mixed with fentanyl or other opioids as a very common polysubstance use. Cocaine had been decreasing, but it is going up again rather steadily, neck and neck now with psychostimulants, although psychostimulants, methamphetamine are slightly ahead. In general, heroin use has gone down, and our deaths from prescription opioids, I think, due to all the good work that people have done about elimination of overprescribing, disposal of appropriate opioids and appropriate care. That's at least one good thing that we can look to. On the next slide. This is sort of the Ohio pattern. Clearly, you've been much higher in the past. You've decreased, but you've had a trend to go up slightly as well. Next slide. If you have not been burdened as much with methamphetamines as other states, that cocaine is still significantly higher than methamphetamines in your state, I would say there's nobody who's escaping methamphetamines right now. It's a very, as we all know, a very highly addictive drug. There are very poor therapies for it. I'll talk about a lot of the efforts we're doing, but across the country, we are really seeing that as really the rising new drug to be mixed or to be used alone. I think we all know the story of how methamphetamine comes in is very different than sort of our classic 1990s, 2000s opioids. Much of it is mixed with opioids, and you would get a mixed substance use disorder and a mixed addiction. But also many people who use methamphetamines have really had awful lives. Many of the people are really broken people with tremendous amounts of adverse childhood experiences, physical and sexual abuse, long roads of real emotional and occasionally mental issues. So there's so much more layers that need to be treated in these individuals with much less good tools to do that with. Next slide. We don't have, as you know, you may have localized reporting areas. We don't have great real-time data about what's going on with the pandemic of COVID and substance use disorders. We look at a couple things. So one thing that we do is we have partnered with Millennium Health that does urine drug testing throughout the country. And we've looked at the patterns on urine drug screens throughout the country, both pre-public health emergency and post-public health emergency. And it is very clear that there is an increase in percent positive of urine tests across the board for fentanyl, methamphetamine, and cocaine, and also a substantial increase in drug screens that are positive for multiple drugs, most typically either methamphetamine or cocaine, plus fentanyl or another opioid. That has gone up pretty significantly, 20 or 30%. It's a convenient sample. We know that, but it's still an indicator. In addition, there's been a few surveys done by SAMHSA as well as the CDC that really shows that those with substance use disorders are increasing both their use of single substances as well as their use of polysubstances because this is compensating for increasing stressors, including, very importantly, the isolation. Many people are unemployed, and many people are also facing many of their relatives either being ill or dying. So we know the stress level of the population is extremely high. And that first slide that I showed you about mortality going up, again, this was really pre-COVID. We certainly expected it to go up even more. Next slide. ODMAP, again, one of our other real-time indices. Again, I'm not saying this is an exact number we should look at, but it's certainly one for a trend. When you look at overdose submissions to ODMAP, they've increased about 20 to 30% year over year when compared to the same time period, and just very significantly increased almost double in January to April compared to January of April in 2019. So again, from another source, very troubling signals of the impact of COVID. And of course it is. I mean, all the social stressors, but all the things that you know about impacting people getting to care or even seeking care to begin with. And I'm not going to say this is parallel, but we know people are not getting their kids vaccinated. Cancer screenings, both mammography, colon cancer screenings, very far down. The number of people coming into ERs with myocardial infarction have gone down, but the number of sudden deaths at home due to cardiac deaths are up. So it's really a pattern of disruption of the healthcare system, combined particularly with people who are struggling with substance use disorder, having the societal and other stressors that we talked about beforehand. And on the last slide, I'll be happy to take your questions. You know, obviously, we're continuing on with our baseline programs. The Healing Community Study, again, I think is very, very important and may pave the way for understanding how do we integrate on a holistic level community-based interventions, and then how do we scale that across the country. All the grants from SAMHSA continue to go out. I think you saw with the last state opioid response grants that there's complete freedom to use that for whatever substances are in your population. You know, if you're on the West Coast or Hawaii, methamphetamines, Oklahoma, methamphetamines is now the single highest cause of death. And that's true, I think, in 16 states now. It's the number one cause of mortality associated. So there's no reason why we should focus just on opioids. It really needs to be taking care of the problem, whatever the problem is. We've tried to continue doing things like fund the workforce. It's been very, very important to us. I think you saw the funding of the addiction medicine fellowships. If I wouldn't have been COVID involved, I would have figured out whether you have them in Ohio. I believe you do. Again, another effort to create more people into the workforce. In terms of methamphetamines, both the FDA and the NIH have significantly increased their funding and attention, particularly in research programs, and the FDA really telling companies they're open for business and are extremely supportive of using all their authorities, fast track, breakthrough, you know, all the authorities to work on new treatments for methamphetamines or other psychostimulants. What you see here are the things that I hope you know we've done within some of our authorities to increase telehealth, to allow for reimbursement for telehealth, allowing opioid treatment programs to provide therapy and counseling with audio-only telephones rather than two-way interactive audio-video telephones. And of course, SAMHSA doing some work with OTPs to allow 28 days of take-home doses. I think none of these are earth-shaking, but they're obvious things that need to be done. What I would really ask of you, as I would ask other communities is, what do we need to do more? There's no stone unturned that we're trying to deal with. Secondly, of these things that are done under the public health emergency, what things need to stay. I think you've seen from the president yesterday with telehealth and our commitment to that I think medicine is never going to go back to where it was. Remember, there were 17,000 seniors who I think used telehealth per week, and now there's over 1 million visits per week. This is a good thing. It's extending care. It's getting to more people where they live. We really need to build up our infrastructure, particularly in rural America, and I think there's going to be a lot of focus on that. That's where we are. I'm interested to hear what you're doing to get your suggestions, and I really appreciate the opportunity to spend some time with you. And I think there were a couple of questions that you had, so let me open the floor to questions or any comments that I could speak to.
Thank you so much, Admiral. This is Patricia Terstengak, and I serve as the moderator with the questions. The first question: how important is nationally maintained guidelines for opioid use disorder versus national advocacy organizations like NAMI or Shatterproof versus professional organizations like American Association of Addiction Medicine?
How important are they? Is that the general question? And you cut off right at the beginning.
Yes, how important is nationally maintained guidelines?
I think they're very important. We've all the types of organizations are extremely important, and they work very well together. Particularly from a legislative area, I think it's extremely important, whether you're dealing with the president or you're dealing with Congress, to have the voice of the professional associations. I think that's extremely important because everyone needs to be evidence-based and guided by the people who have their boots on the ground. I would say it is also extraordinarily important to have patient advocacy groups. And when those groups line up then you have a truly winning combination because everybody's motivated to do the right thing. There are a few political, and I would say there's some stigma barriers. They are decreasing substantially, but they are still there. But when you see both groups line up, I think that's extremely important. Now, guidelines, to the extent that we can coalesce around single guidelines, I think that's all important, and we're all victims of this. I mean, even at HHS, I think we had 5 sets of recommendations for dealing with neonatal abstinence syndrome that we needed to coalesce and really even understand what the definitions are. So I think all groups are really important. I think to the degree that we can coalesce or at least make the guidelines aligned in certain ways, that's always better to eliminate confusion. And that's certainly one thing that I think SAMHSA has worked very, very hard on trying to do that. And of course, my office too.
Thank you. Our second question is, how do you suggest hospitals balance their need to implement safety measures related to COVID-19 while still finding a way to treat those individuals with the most severe addiction, individuals who often require an inpatient admission?
It's going to be hospital by hospital, but one thing that we don't want to have happen is essentially lose the rest of healthcare during the middle of a COVID outbreak. And we saw in March, April, and in May that essentially the healthcare system was shut down. And now I don't mean that literally, but metaphorically, the numbers of procedures, the screenings, the preventative care, as I mentioned, were dropped tremendously. Where we are right now, and let me give you a COVID moment. If we can get all communities to wear a mask, to physically distance, to avoid crowds, especially crowded indoor spaces like bars or restaurants, because we know, or at least we believe, there is some airborne transmission, and certainly in bars, you're close. And to do good hand hygiene, we have seen outbreaks turn around on a dime. Governor Ducey from Arizona is here in Washington today. We really instituted those simple measures in Arizona. We bumped testing a bit, but certainly not to the levels that the basement epidemiologists are calling for. You know, those that go on CNN every night but really have not been out of their basement in 4 months. You don't need to do that. It's good to have testing. I'm promoting testing, but if you do those mitigation measures, you can turn things around. So the number one thing to do is preach that in your community, because if you can keep COVID under control until we get a vaccine, you'll be able to have hospital capacity. And unless you're in places like South Texas or Southern California right now, the hospital capacity is really good. And again, I think we need to walk and chew gum. You know, when you're in the hospital, you need to be prepared and do all the types of things we need to do for infection control. But, you know, we can't let people with substance use disorders go without treatment unless we're into an absolute triage situation, which we're not nationwide. Nationwide, we're in a pretty good shape. Even with this latest outbreak, our hospitalizations are down. Those in the hospital are down about 15,000 from the peak, and we're doing pretty well. So I think we can do both, and you know, it's going to be an infection control issue, but as long as we have the capacity, you know, we want those people hospitalized, right? Just like we don't want people dying of MIs at home, and we don't want another 20 or 30,000 women to die of breast cancer in the next few years because they haven't gotten mammograms. So, I mean, all these things need to fit together.
Thank you so much. I believe Camille or Dr. David Stream will walk us to the next section now.
Yes, thank you so much, Admiral, for your kind words and your office's support of our efforts to address this terrible problem, particularly in these challenging times.